has no respect for fame or fortune, nor for sex, nor age. Pain and its alleviation. This is alleviation of pain on an intuitive level. The patient's normal reactions and characteristics are well known. The degree of pain may be calculated. Here, the extent of tissue damage bears a close relationship to the intensity of the pain signal. Early in life, man learns that this mysterious signal is to warn him of something wrong, and willfully or instinctively, he attempts to avoid or relieve the pain. On a professional level, alleviation of pain is highly complex. Here, decisions may be instinctive. But usually, alleviation is based upon due consideration of all possible contributing factors. When the nature of pain and its probable duration are unknown to the patient, such elements of mystery make the sensation doubly ominous and magnify the problems of alleviation. The very presence of the nurse often gives great comfort and support to the patient. To the nurse, pain is no great mystery. To alleviate pain on a professional level involves study, practice, research. Pain. What is it? If on a normally sensitive area such as the skin an injury is sustained, impulses are generated and transmitted through the peripheral and central nervous systems and register in the cerebral cortex as the sensation of pain. Nothing is flowing back along the nerves over which impulses have traveled. This reference of a sensation back is purely a mental process called projection. Pain at the site of injury is projection of sensation.
And after medication, the patient, having been freed from pain, was able to cooperate more fully, and early recovery now appears to...
He'll be okay. Oh, God, where's the doctor? I don't know. Let's find him. I think the burn is just terrible. Oh, where's the doctor? I'll be back. I'm hanging there in just a moment. Please, Teresa, let me take a quick look. I've been touched.
Emergency, maybe second degree. Pain intense, and I can't stop it. Must act fast, no time to talk. Wish I could calm the mother. She's tense.
You better clean off as much grease as you can.
Get the grease off fast so as not to prolong the pain. The quicker I can do it, the less pain Jimmy will have. Must let him know I'm on and tell him what's coming up.
Pain is an angry thing. It can explode into 1,000 burning fragments. Alleviation can mean the subduing of these many sparks in order to relieve the hot, heavy weight of pain at its source. For pain can weigh 300 tons. Why does it hurt? How long will it last? Can they do anything? What will they do? Was it my fault? Will I die? Pain is a mysterious monster that looms large in the darkness of the unknowing. The healing light of reason can cause the monster to retreat, its sharp claws being dulled. Alleviation can be like driving 17 horses at once. Each unbridled force must be controlled, guided, and urged forward. In a case of accidental injury, there is always the question of guilt. Who was at fault? Who had a part in making possible this pain? Each must be reassured. An accident is a thing of chance. It may, as here, also be a contingency. Accidents contingent upon conditions that are unforeseeable can well be fortuitous, wherein no injury takes place. It is all a matter of chance. If all who are involved can be led to believe that the accident just happened, then each is more able to support the other, rather than generating further problems because of their own concerns. This is especially true within the family group. They must live with each other. An accidental injury to any one is a family problem.
And we had a long talk afterward. Physically, a clean but painful injury. Should heal well. No problems on the cultural level. Emotional reactions about normal, considering the number involved.
Sudden, unexpected pain can strike with electric shock. Dietary or systemic weakness can cause a gallstone to form or lodge in the cystic duct, blocking the flow of bile. Involuntary muscular contractions seek to dislodge the obstruction. During spasms in the duct, distension is severe, pain is deep. Antispasmodics are often a first step.
What were all those other medicines they gave me?
Well, one was to relax the duct, which would let the bile through, to prevent the pain of a spasm. Did you have much pain? I hope you're more comfortable now.
The medicine with your explanation about gallstones. Am I going to have surgery?
We don't know yet. Dr. X-rays. Sometimes stones pass right on through.
Oh, you'll never know what I've been through.
Oh, it must have been awful.
Oh, it was awful. It was just like a sharp, jagged knife cutting through me, jabbing right through me.
That could be most frightening. Where was the pain?
Well, I've never been sick a day in my life. Oh, a little indigestion now and then. But this? Oh, where? It was right here, below my ribs. Well, actually, it was my whole side. And then I got older. Well, if it's gallstones, why should my shoulder hurt?
That's called referred pain. You see, your nervous system receives a signal that something's wrong.
Alleviation can consist of attention, support, distraction, explanation, comfort, peace of mind, a logical acceptance of reality, all enemies of pain. Pain thrives on mystery and anxiety. Alleviation can also be the evaluation of the many things that may be causing pain or discomfort, and the selection of those measures of care that are most needed. This is made easier by knowledge acquired in a previous relationship.
The incision is painful. So is the abdominal distension. Would moving her be enough? Or should it be a Harris flush? Throat may be sore from the tube. Should look into that. She's getting a lot of glare from the window. The IV is probably highly uncomfortable. Hand is really rigid. She's been on her back a long time. Circulation problems. Needs repositioning. Maybe a back rub. I'm going to do something to make you more comfortable.
Oh, nurse, I feel so miserable. I hurt all over, every inch of me. You've got to do something to help me, or I'd sooner you'd leave me alone, and I'll just die.
I'm going to get some medicine to relieve the pain. I'll be right back.
Pain cannot be measured like other quantities or volumes. It can only be reported. In some cultures, reporting is conditioned or completely absent.
Are you in pain?
I ain't jumping like I could be, sister.
I know it hurts. Where?
The nurse is trained to recognize these differences in response, to evaluate the approximate degree of pain being experienced, and to act accordingly. A differential may be established between the person who is naturally stolid and one who, through cultural experience, has acquired the philosophy of the Stoic.
Looks uncomfortable. They say he had a pretty good day. Maybe he has nighttime blues or is just lonely. He never complains, but his illness often causes pain. Are you having pain?
Yes. I have pain.
Where? What is it like?
There. It's nothing, really. I'll be all right.
Observation can usually reveal the existence of pain signals in those inclined toward the non-verbal. An approach to the assessment of pain and prediction of effective measures of alleviation may well differ from the approach used with those who are somewhat verbose or demonstrative.
I just can't stand it. Nurse, forgive me for troubling you, but I just can't stand it. Hand me another kerchief, please. No, the organ one. Oh, I feel so horrible.
When did it start?
I felt much better before my operation. Isn't that light awfully bright?
Where does it hurt?
Really? No one should be expected to suffer this way. What have I done to deserve such pain? Call my doctor, miss.
You're probably having gas pains. Distension is not uncommon for patients that have had this type of operation. Yes, you do seem to have distension, mostly on the right. I believe you'll be more comfortable if you turn to your side.
Oh, no, nurse. That'll put all the weight just where it hurts the most.
Gas accumulates in the large intestine, stretching it beyond normal and causing pain. Now, if you move, the gas moves, relieving the pressure and the pain. There. Now the gas can go up the transverse colon and out. Now, how's that?
Why, I feel better already.
That's fine. Now, I'll be back soon to see how you're getting along.
Honey, come back soon. And often.
Doctor, you're killing me.
Here, hold this. Only a few more stitches.
Early cultural experience can often overweigh later intellectual and physical development in relation to response to pain. Physical characteristics may be highly deceptive as to possible patient response. They may be in parallel, or divergent, or mixed. Any clue to cultural conditioning could be of great help in such an evaluation.
Hurt?
Sure does.
IND abscess. You seem to place a high value on self-restraint. A few moments now. What else can I squeeze in? Mr. Purcell. Oh, probably best tell him it'll soon be time to get up. He doesn't like to be taken unawares.
Oh, dear. Oh. Hi, girlie.
How's the arthritis this morning, Mr. Purcell?
See, I got my knees down.
Yes, I see.
Now, what do you have to keep rubbing my knees for? They're sore, you know.
We must keep them flexible, limber, so you can get around and see things.
See things? Oh, I've seen everything already. Have you hand me my tobacco, will you? Thank you.
See things and people, your old haunts, friends, places.
Yeah. Well, let them come and see me.
Oh, come now. You want to be your own boss, don't you? Do what you want, when you want? Actually, it'll soon be time for you to get up.
Girlie, you sound just like my old lady.
And I'm going to see what I can do about some visitors for him. But Mr. Purcell is better. He has no severe pressure areas, no contractures. I plan to get him up this afternoon. Of course, he still has appreciable pain.
Respiration okay?
Yes, although he does object to being turned. Strenuously.
Wonderful fellow.
You know, he really is.
Pain, when its causes or its consequences involve mystery, often results in some degree of anxiety. The element of mystery can expand to the point wherein the patient feels that he should indeed close his eyes and lips, feels that his initiation into the mysterious is being carried too far. He may doubt his own ability to cope with the situation. His instincts are to flee or fight. Even minimal anxiety is an emotional state that affects the heart rate, respiration, vasomotor reactions, muscle tone.
Oh, nurse, I'm so glad you came.
I brought you some milk. You had so little dinner.
Oh, thank you. Oh, nurse, I'm so worried.
What's the matter?
Oh, my stomach feels so heavy, and now the pain's deep and boring, too.
Boring pain?
Yes. I've had it several times during the past few weeks. Do you suppose I have cancer?
We don't know. You are worried about it, aren't you?
Well, my husband says that with female troubles, anything can happen. Sometimes I wonder if Harry's afraid that I won't be able to be a good wife to him any longer. Oh, if only I knew. He's such a good guy. So are the kids.
Here, anxiety is normal in proportion to the threat as perceived. Mystery, the element of the unknown, has affected the degree of symptom response. Should the mysterious threat be greater, anxiety can achieve a level wherein behavior may become peculiar, even antisocial.
Let me help you.
I'm okay. Don't touch me. Where's the doc?
Please be seated in the treatment chair. The doctor will be right in. He can't see from his left eye. Instrument maker. Precision work. He's really worried. Must be afraid of loss of vision. So, unable to work and support family. Sure is mad at everybody, including me, and probably himself. Needs help badly, but we'll fight it. Well, here we go. Let's clean that up and see what you have there.
That hurts, damn it! Look, will you just get the doctor?
Here, hold this. So we'll just clean the blood away. Yes, your eye looks all right.
My eye, all right? Is it bad?
Well, a few stitches will pull it together nicely.
Take it easy, will you?
Nurse, get me some more 4x4s.
Nurse, how much longer?
Looks like the doctor's nearly finished.
Once the threat to the body image is dispelled, anxiety usually diminishes or disappears completely. Threat, anxiety, pain. Often these feed on each other. Over prolonged periods of time, the patient may acquire an undue fascination with each facet of his condition. He is inclined to embrace the mystery. He begins to lose touch with reality.
Get me some milk.
I cannot do that, sir.
Get it, I tell you. Nurse, I must have some milk. My stomach is on fire, and these horrible pains. It's gotten so that I can't eat, or you won't let me.
Now, you must have your stomach empty for your x-rays. You'll be getting some barium to swallow soon.
Nobody seems to know when I'm to go in. Why don't they have a schedule around here?
I'll call and see what time they have you down to go. Maybe we can move up your schedule.
Well, thank you. Last time I was in, they sent me to x-ray at the wrong time, and I missed my medicine.
Missed your medicine?
Sure. See, that's where you're wrong. They were supposed to bring it in on the hour, and they took me to x-ray 10 minutes early, so I missed my amphigel. Oh. It's better than calcium carbonate. That's chalk, you know. And besides, it constipates me. Ampho is much more effective, particularly if I take a little fluid with it. But do you know what they're doing at night? I finally talked them into giving me Seconal instead of Nimbutol, and they never give me more than 1.5 grains of Seconal at a time. I need 3 grains to hold me. Oh, they're giving me this Milltown. I know all about these tranquilizers. They think it's all my nerves, but I know this pain is real, and I ought to be getting an analgesic.
An analgesic?
Certainly an analgesic. Instead, all they talk about is neurotic anxiety. May's terminology, as if you didn't know. Oh, I've asked my doctor to call in a consultant, but he wants me to see Dr. Antrell, state board, you know. But he doesn't understand my case. Just another head shrinker. Say, you don't talk much, do you? You're the only one who's ever still around here. The rest seem to run around all the time. Oh, can't they get anything done? Oh, nurse, I'm sure you really understand that I have a severe physiological problem. Intense pain. Last week, I had a board-like abdomen. Pain on rebound. This week, there's this terrible epigastric burning and gnawing. Oh, now don't try to give me a placebo. I'm too smart for that. Oh.
Seemingly severe hypochondria. Gave all the help I could. X-ray may be definitive. Long range, encourage him to accept psychiatric help.
Do something.
Almost completely severed. I'll go scrub him.
Doc, can you save it?
If we're both extremely lucky.
No, Doc, no, not that! Do something!
What else, in God's name, can a nurse do?